Hello, everyone, and welcome back to Karan Academy. My name is Karan, and today we're going to be talking about heart failure. Now, I'm sure you all are aware that heart failure is going to be one of the most high-yield concepts you're going to study this year. I am a firm believer in the fact that this is a condition you cannot memorize, and I think you absolutely should have a system of understanding the different types of heart failure, differences in presentation, and then having a good understanding of how we classify its severity, how we treat them, basically to the point where if you saw a patient with heart failure, you should be able to walk them from point A to point B quite comfortably. Important to know, so what is happening with heart failure? Heart failure obviously is going to be a situation where your heart is unable to meet the metabolic demands of the body. This is predominantly due to some change in the myocardium itself. So at your level, now that you've just entered clinical years, what are some things you want to be able to identify and know with congestive heart failure? Firstly, you need to identify the disease based on signs and symptoms. You need to identify likely causes based on the patient's history. You need to be able to categorize what kind of heart failure is this, and we'll talk about that as well, and understand why do certain types present the way they do. You want to be able to categorize this in terms of how severe the heart failure is, because that's often going to be one of the major factors driving our medical therapy. And lastly, how would you manage both the acute side of things as well as their chronic management? Because obviously this is going to be a chronic issue that they're going to be facing. Going back to our cardiovascular risk factor screen, three of the most common causes for heart failure include ischemic heart disease, hypertension, and valvular diseases. You can also have cardiomyopathies, which we'll talk about in another lecture, and as well as medications like alcohol, which is known to cause dilated cardiomyopathy, cocaine and meth, which are also associated with different other cardiac pathologies. You can also have autoimmune diseases like SLE and vasculitis that affect the myocardium. But the three ones you need to know inside out include ischemic heart disease, hypertension, and valvular diseases, and how they affect the heart. So I know physiology is often not the most fun topic to study, but I think once you understand this, it's one of those things which you will never ever forget. And that's really what I want you to get out of this lecture. Heart failure is basically a situation of low cardiac output, right? If we go back to our basic equation, we know that the cardiac output includes the stroke volume, which is the volume of blood the heart is able to pump out with each contraction, multiplied by the heart rate, which is going to give us the amount of blood the heart is going to be able to pump out per minute. We also know that the stroke volume basically is the amount of blood at the end of diastole minus the amount of blood at the end of systole, right? You are going to fill the heart up during diastole. Hopefully your ventricles are full of blood, and then you're going to pump them out into the aorta and the pulmonary artery. This is not always going to be 100% of the blood. You're almost always going to have some blood left off after. That's going to be the end systolic volume, right? If you subtract the two, you get the actual volume that was pumped out. Within just those three steps is most of what you need to know about heart failure and understanding why things happen the way they do. Every single cause of heart failure affects something within that equation. So once you understand that, it's going to be such a huge help. So let's explain that, right? So let's take the example of ischemic heart disease and talk about what's happening there. You have Bob. Bob is 55. Bob never really looked after himself much. He had a whole bunch of cardiovascular risk factors, had a heart attack at the age of 50. Thankfully, he survived, but has been left with some form of ischemic heart disease that's still ongoing, and it is limiting to him to some degree. Well, what happened with the heart attack to begin with? Well, you obviously had part of the myocardium that died away and was replaced with fibrous tissue. Now, as you know, that fibrous tissue is going to be not as strong and not as elastic as good old myocardium. Over time, that's going to dilate, right? And you're going to end up with something called a dilated basically dilated left ventricles. What does that do? So once your left ventricles are dilated, well, it kind of seems like a good thing, right? Because the dilated ventricle means there's going to be more blood flowing into it. Well, that's half of it. Although you do have more blood flowing into the ventricle, because so much of the ventricle itself is made of fibrous tissue and not good myocardium, you're going to struggle immensely with getting a lot of that out, which is why, although your end diastolic volume may be high, your end systolic volume is also going to be very high, which is something we don't want. We don't want to have a high end systolic volume, which means that our stroke volume is going to be low, times the normal heart rate is going to have a low cardiac output, right? I have another example on the next page, but again, understanding the pathophysiology really helps. So you need to ask yourself, is there an issue with filling of the ventricles? Is there an issue with the contraction, or do you have a bit of both? Once you understand these, then I think it's relevant to look at the ejection fraction and to understand what's actually happening. So ejection fraction basically refers to the volume of blood that's pumped out with each contraction divided by the total blood that's filled in the ventricles right before it contracts. So we had a case here that we talked about with the heart having good diastolic capacity. It's still filling up more than what it probably should, but because it can't contract, because it has big floppy ventricles, you're not going to get much of that blood out, which is why you're going to have a reduced ejection fraction, right? Does that make sense? Because again, a lot of volume of blood can't get much of that out. So the fraction of what you can get out is going to be reduced. Okay. On the flip side of that, let's take a completely other person who has, again, a whole bunch of cardiovascular risk factors. He comes to his GP because he's been feeling short of breath. He has some swelling in his feet. I also realized I've misspelled feet, and is found to have a blood pressure of 160 on 100. Now, very straightforward, you know this person has hypertension. Why does this person have hypertension, now you ask? Well, it's a good question. Probably because he hasn't been looking after himself a whole bunch. You're going to have a whole lot of systemic plaques causing the high pressure. Because you now have a high systolic pressure, it means that it's going to be much harder for your left ventricle to pump a whole lot of blood through the aorta, right? What does your heart do? Well, your heart keeps saying, well, I want to pump more, I want to pump more. In doing that, it tries to strengthen itself like any muscle does. So what it does, it hypertrophies. But remember, your heart is dumb, and most of the things that your heart does tend to be dumb too. So although now you have super strong hypertrophied ventricles, you have indirectly, and without wanting this, caused a reduction in the actual volumetric capacity of the ventricle. What does this mean? Now you have a big, thick heart wall, but the actual volume of the ventricle, the left ventricle, which is going to fill up with blood, is going to be much less than what it used to be. So now what's going to happen? During diastole, well, your ventricle is going to fill up, but because the wall itself is so thick, it's not going to have much space to fill up in. What happens then? Well, when it does contract, because your heart muscle is so hypertrophied, well, it's going to still contract pretty well, and it's going to get most of that blood out, right? So if you look at the ejection fraction, it still kind of makes sense because you're still getting most of the blood out, right? However, the issue is not with the amount of the blood you're getting out compared to what you have. It's the fact that you don't have much to begin with, which is why hypertension and left ventricular hypertrophy that results in heart failure has a preserved ejection fraction, which is why if you see a normal ejection fraction, don't be quick to dismiss heart failure, because you still can have heart failure with a normal ejection fraction. Hopefully this makes sense so far. So in terms of classifying heart failure, there are two broad ways you can do this. Well, I'm sure there are more than two, but the two main ones. You can either classify this based on the ejection fraction, and this can either be HFpEF or HFrEF, standing for heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Now, this is more useful in terms of dictating management. However, an approach that's more pragmatic for when it comes to history taking and examinations is going to be based on ventricular involvement. So is this left-sided heart failure or is this right-sided heart failure? Now, you may be asking, well, how does that help me? Well, it helps because if we identify one part of the heart that's more doing a poorer job compared to the other, everything behind that is going to suffer. Let me try to rephrase. If you have the right side of the heart that's short for some reason, it's not going to be able to pump blood that it's meant to receive, right? You know that the right heart receives blood from the systemic circulation, right? If your right heart is not functioning well, all that blood that it was meant to pump away from the systemic circulation is going to backflow and pool up in the systemic circulation. This is going to go to your feet. This is going to go to your belly. This is going to go to your liver. It's going to go to your JVP. That's right heart failure. Versus left heart failure. As you know, the left heart pumps blood from the lungs into the systemic circulation. Now, if it can't do this, you're going to have more blood pooling up in the lungs, which is where you get more of the lung involvement. You get shortness of breath, you get exertional dyspnea, you get orthopnea on lying down, you get paroxysmal nocturnal dyspnea. All of those are quite typical of left heart failure. Now, it's quite common to have both left and right heart failure together, which is what we call congestive heart failure. And in that case, you would see a combination of both left features and right features. And here's a good summary of that. So with a reduced ejection fraction, the dysfunction is systolic, or it's a pumping defect, as we talked about with the heart attack case, right? Because the heart is not able to pump well, although it's filling well, you're going to have reduced ejection fraction versus HFpEF, where you're just not filling enough blood. The structural changes have been mentioned, and you can often observe cardiomegaly with reduced ejection fraction heart failure because you have a dilated ventricle. On exam findings, you can have a displaced apex beat for the very same reason, and you're going to have an apical heave with a preserved ejection fraction. Again, going back to basics, why do we have that? Well, we have that because we have a hypertrophied left ventricle, and a hypertrophied strong left ventricle is going to thump strongly against your hand when you place it there, causing the apical heave. Now, there's a specific test I want to talk about called the brain natriuretic peptide, or BNP, that's quite useful for heart failure or diagnosing heart failure. It's an enzyme that's released by the cardiac myocytes, often during dilation. So if they're stretched, they tend to release, or you tend to have higher levels of BNP, which is why you often see high levels of BNP with HFrEF, but this may not always be the case for HFpEF, which is why, again, if you see a normal BNP, don't be quick to dismiss HFpEF if you have symptomological signs of heart failure. Again, talked about left versus right. I have most of the signs here for your reference that you can look at, pause and read through, but we've already briefly talked about this. So how do we diagnose this? Obviously, patient comes in, you're going to start off with a history and an examination. You're going to focus on their cardiovascular risk, and in your head, try to fit in their symptoms with, is this left-sided or right-sided? And based on their history, have they had anything in particular which may make me think of HFpEF versus HFrEF? If you can then also go and assess the severity of their heart failure, which we'll talk about in a second, that really shows that you are thinking about all major aspects of the condition, and it's going to guarantee a really good score when it comes to your OSCEs. Investigations here serve two roles. Firstly, confirming, do they have heart failure? And then secondly, if they do, why have they deteriorated in this moment in time? Right? Heart failure doesn't develop overnight. So something has happened that's pushed them over the edge. What is that something? So ECGs are always good to do. A BSL, they may be diabetic, and diabetic or poor glucose control can be a really key factor in their deterioration. A urine dipstick for infections. In terms of bloods, you can do a baseline blood, but also TSH. If someone is hyperthyroid and has increased cardiac demands, that can throw them into heart failure. BNP versus pro-BNP. Pro-BNP is just a precursor for BNP. Both reflect the same thing. And with imaging, you can do a chest X-ray to look for those lung signs or acute pulmonary edema, and we'll talk about what those signs are in a second, and also an echo to determine what their ejection fraction is. And I've talked about all that as well. So assessing their severity, the one severity assessment for heart failure you should know inside out is the New York Heart Association classification of heart failure. It's divided into 4 classes, going from no limitations to physical activity to some limitation on physical activity. It's also good to, I guess, have an example for each one, because remember, your patients are not going to be able to tell you whether it's slight or marked. So class 1, they can go about their normal day and often have no symptoms. Class 2, when I think of class 2, I think, oh, the person is usually fine, can walk around, but if they climb a few flights of stairs, they might get short of breath. Class 3 is they aren't symptomatic at rest, but let's say if they had to walk to their front door or get the newspaper or go to the letterbox, they might have some physical discomfort. And class 4 is that they have severe discomfort with any physical activity, and they may have symptoms even at rest. APO, or acute pulmonary edema, is another complication that's really important to know about. So APO, as I mentioned, is going to be quite predominant with left heart failure, but often you have left and right heart failure coexistent. As a rule of thumb, always be aware of the isolated right heart failure, because the right heart failure alone often indicates something else going on. Like you may often have a lung pathology or pulmonary hypertension that's causing backup and right heart failure. So never be quick to dismiss right heart failure in isolation. Going back to APO, so it's a very common presentation of heart failure, and it's why they're short of breath. Why are they short of breath? Well, because with backing up of blood into the pulmonary vasculature, because of that increased pressure, there's going to be fluid seeping into the alveoli. That's going to cause alveolar edema, and that's commonly seen as the batwing sign. As you can see, you have kind of this increased opacities in these midfield zones. That's called the batwing sign. You may have curly B lines, which are these fissure lines. As you know, you have different lobes, and normally you should not be able to see the fissure lines, but that can commonly be seen with APO, because again, you have fluid in those lines. Cardiomegaly, especially with heart failure with reduced ejection fractions, you can have dilated pulmonary vessels, which are very hard to spot, but it can often be, again, because of that backflow. And pleural effusions are another big one. And for that, we look at the costodiaphragmatic angles and the cardiophrenic angles. Next, going on to why did they deteriorate? So we know that they've deteriorated. Some important reasons why. So firstly, we want to treat whatever the cause is, and secondly, educate them of what happened so we can prevent that from happening again. So either they've not been compliant, they've not been taking their medications, taking too little or too much, they've had an introduction. Arrhythmias, the most common one being AF, can often throw people into heart failure. An ischemic event, so they've had perhaps a silent MI, they have an infection elsewhere that's caused an increased cardiac output demand, and the heart just can't cope up, or they've been put on certain medications like steroids. So how do we treat them? So acutely, our goal is to correct the cause. Whatever the cause is, you can treat the cause. Oops. And our goal is to get the fluid out of the lungs, because that's what's causing their symptoms. So a good way to remember that is going to be our LMNOP acronym, and we start from P and move all the way to L. So first thing we do is positioning. We want to sit them upright. We know that laying flat is going to make their symptoms worse. If they are desaturating, we want to give them oxygen. Nitrates, because it's going to help open up some of those vessels and increase reduce their symptomology. Morphine is good because they might be in pain, but also morphine acts as a vasodilator. So again, can help with symptoms. And Lasix or furosemide is going to be a really good diuretic to help offload some of that fluid, because they may often be fluid overloaded too. In the acute setting, you can often always re-emphasize the importance of fluid restrictions, diet changes, exercise, and salt restrictions. A good question that I think, hopefully, based on what we've learned today, you'd be able to answer logically without having to mug up an answer is, why do we, I'll tell you as a fact, that we tend to avoid diuretics in someone with heart failure with preserved ejection fraction. My question to you is, why do we avoid this? Pause, have a think. So the reason we avoid diuretics in someone with HFpEF is going back to the root reason as to why they have their symptoms. Someone with HFpEF is symptomatic not because they are fluid overloaded, it's because they're actually not getting enough blood into the heart to begin with, right? Versus someone with dilated cardiomyopathy, they're getting too much blood in, they're fluid overloaded. HFpEF, they don't have enough blood going in. So giving someone Lasix and further reducing their fluids can often be detrimental. You also need to know that HFpEF can often progress onto HFrEF. Well, how does that happen? You start off with the picture where your heart is hypertrophied. Over time, when it can no longer keep up, it weakens and tends to balloon up, and then you end up with HFrEF. In terms of chronic management, you never want to forget education and lifestyle changes. Very, very important. Salt restriction and fluid restriction are very, very important. Usually, it depends on how severe their heart failure is, but a good rule of thumb is 1.5 liters a day. You want to ask them to weigh themselves quite frequently, usually once a day. And if they notice a significant change, they can either adjust their dosage themselves, adjust their fluid intake, or if it's really bad, they may get in touch with their GP or the emergency department. And then you also talk about their cardiovascular risk and steps to minimize that. So again, talking about metabolic syndrome, obesity, hypercholesterolemia, hypertension. Pharmacologically, there have been only 3 medications that have been shown to help with the long-term prognosis and increase their survival. And an acronym for that is ABS, like the braking system. A good way to think about it, ABS puts a stop to their disease in a way, and that's going to be your ACE inhibitors, your beta blockers, and spironolactone. I know we talked about furosemide and diuretics. Diuretics like furosemide itself, they help with short-term symptom control, but have not been shown to affect long-term or improve long-term prognosis. That's all we had for heart failure today. I hope that all made sense. If any of it didn't, please feel free to get in touch with me on my email. I'm more than happy to answer any questions. And as always, please look after yourself and please look after your loved ones. And I'll see you guys next time.